my great pleasure to introduce my friend Ken Silverman to you all. Ken and I were talking yesterday. We met about 40 years ago. I was a fresh graduate student. He was a year ahead, and I didn't know what was up. And if he didn't intervene, I probably would have got thrown out of the program. So I'm very grateful to him. He then, after doing something which I can't even remember what that is, went to Hopkins.
Don't even think about it.
Did a postdoc there and was so good they wouldn't let him leave. Now he's a full professor there. And he's always thinking about how to maintain behavior change over extended periods of time. So many of us are just focused on producing brief changes. He's thinking about the long term, and you know I like that. So without further ado, my good friend, Ken Silverman.
Yeah, thanks. Well, thanks, Warren. Well, we have known each other for 40 years. He went to Einstein School of Medicine. I didn't see him there. But I've seen Vermont, Arkansas, and I never was here. So I'm really happy to be here. I had a great time visiting with people and learning about what you guys are up to. I'm not too sure if this is better. It's a pretty impressive little operation that's going on here. So I'm going to talk about research that we've done over a pretty long period of time on developing an operant treatment for heroin, cocaine, HIV in people who live in poverty. And to some extent, trying to address poverty, but we haven't done all that much. It's that impressive about that, but we're trying. A bunch of people have contributed to this over the years, and they're listed here. Poverty is bad. But besides the obvious reasons that it's not good, it's associated with a lot of bad health problems. This is just a list of some of them. And these are data that show that your lifetime expectancy is related to income. So the red points represent women and the blue men. And you can see that women at the lowest income level live about 10 years less than women at the highest income level, which is equivalent to a decrement in longevity that you might expect from a lifetime of smoking. And men at the lowest income live 15 years less than men at the highest income. So there's two ways that you could, at least two ways that you could address this problem. One is health problems in people who live in poverty. One is a proximal intervention to promote health behaviors or health in people who live in poverty directly, and the other is to develop distal interventions that attempt to reduce poverty. Most of our work is on the first type, and that's probably what most people do, and partially it's pretty hard to reduce poverty. So we're working on that and very interested in it, and we've made some feeble attempts to address it. So first, we've done some studies of that first type to try and use operant conditioning to promote abstinence in people who live in poverty. One thing I should mention also, is that I'm just an operant conditioner, and all we do is provide operant treatments, operant conditioning to address problems. So we've done some studies on using operant conditioning to promote abstinence in people who live in poverty. And a lot of our work is focused on methadone patients, who many of you are probably familiar with. People who have heroin dependence use methadone. It's a pretty effective medication that people take every day, and it can reduce use of heroin or other opioids, people who are in treatment. And it also is a positive reinforcer. Methadone is a positive reinforcer itself, tends to retain people in treatment, but it has no effect on cocaine use. And a lot of people in Baltimore use cocaine who are also in methadone. I'm not sure what the story is here. In California, methadone patients frequently use methamphetamine. But so we focus on cocaine in methadone patients, a lot of our research. We've also focused on injection drug use, in large part because injection drug use has been associated with increased risk for HIV infection. This is whether you've ever injected increases as a function of decreases in income. So people with the highest income, your lower probability of being an injection drug user compared to people with the lowest income. So as I mentioned, I'm just a plain operant conditioner, and the analysis of drug addiction is frequently viewed as operant behavior maintained by drug reinforcement, and I'm sure many of you are familiar with that. And this is a paper written by Bob Schuster and Travis Thompson in 1969, a long time ago, in which they said the behavioral aspects of drug dependence can most profitably be interpreted within the framework of operant conditioning principles. And I think that's right. So operant conditioning has been applied in the treatment of drug addiction in a variety of ways, and probably the most effective way has been the direct reinforcement of drug abstinence in procedures that are called abstinence reinforcement interventions. And under these procedures, patients receive money or privileges contingent on providing drug-free urine samples. So these have been used for a long time. This is a review paper by George Bigelow in 1989. One of the most effective abstinence reinforcement intervention was developed by a friend of Warren's and mine, Steve Higgins, who we also know for 40 years. Steve went to Vermont. Actually, he went to Hopkins as a postdoc, as Warren did, and they moved to Vermont. Steve tried to effectively treated people with cocaine dependence, and he developed an intervention in which people received monetary vouchers exchangeable for goods and services contingent on providing drug-free urine samples. And in his case, it was cocaine-free urine samples. People could earn about $1,000 in vouchers over a 12-week period. The magnitude of the vouchers, probably a lot of you are familiar with, increases the number of consecutive cocaine-free urines increased. And he was very effective in promoting cocaine abstinence in primary cocaine-dependent patients in Vermont. So we used a similar voucher intervention when I first started this work to promote cocaine abstinence in people who were in methadone treatment but still using cocaine. This is the design of the first study that we did. And people had a baseline in which they were in methadone treatment for 5 weeks. People who continued to use cocaine got randomly assigned to 2 groups, a abstinence reinforcement group or non-contingent voucher group. Abstinence reinforcement patients could earn vouchers exchangeable for goods and services for providing cocaine-free urines over a 12-week period. They could earn $1,155 in vouchers for providing cocaine-free urines, using a system similar to Steve did. And patients in the control group received vouchers on a non-contingent basis, yoked in pattern amount to patients, to vouchers received by patients in this group, but not contingent upon drug-free urine samples. So this slide shows the longest duration of sustained cocaine abstinence that patients in that study achieved. And people exposed to the abstinence reinforcement intervention achieved between 7 and 12 weeks of sustained, half of them achieved between 7 and 12 weeks of sustained cocaine abstinence, and only 1 person in the control group achieved more than 2 weeks of sustained cocaine abstinence. This was pretty good effect. It still is actually a pretty good effect in treating this problem. It demonstrated the value of this voucher intervention, but it's also true that some people didn't respond to the intervention. Some people appeared relatively resistant to the intervention. So we conducted another study to see if we could affect treatment refractory patients by increasing the magnitude of reinforcement. You know, it's not amazing, but it's a pretty simple and straightforward idea. And we took patients, getting methadone patients who used cocaine. We offered them $1,155 over 12 weeks for providing cocaine-free urines, and we only took people in this study who failed to initiate abstinence. So those are shown here. Some people did initiate abstinence, and they didn't get in this study. So we took those people, and we exposed them to 3 9-week conditions in counterbalanced order using a within-subject crossover design. a 0 magnitude intervention, low magnitude in which they could earn $380 over 9 weeks, and a high magnitude intervention in which they could earn $3,400, a kind of insane amount, over 9 weeks for providing cocaine-free urines. But, you know, which is equivalent to like a $20,000 a year job. But a lot of these people initiated cocaine abstinence. So these were all, you know, injection drug users. They didn't stop when they were offered this $1,155. A lot of them, 72% of them reported sharing injection equipment in the, during the study. A bunch of them, 14% or more, were living with HIV. And we couldn't get them to stop offering $1,155, but they did stop using this high magnitude intervention. So however crazy it was effective. So this is the people in the high magnitude condition, and each row represents data for a different person, and these are consecutive urine samples. So you can see this person, and the solid portions represent cocaine negative urine samples. So this person maintained high rates of cocaine negative urine samples, and so did a bunch of these other people. Some people had some delay in initiating abstinence. And this is kind of a different way to show the same data that I showed you before. But a lot of people in the high magnitude condition initiated cocaine abstinence. This is the unfortunate reality, and that is the end of the voucher intervention at this dashed line. And a lot of people, as obvious, just relapsed to cocaine use during that period. Now, we kind of expected that. I mean, more than kind of. We did a within-subject crossover design because we expected that people would relapse when in between the conditions. You know, scientifically, that was a kind of convenient thing. It's not too good clinically, but it's just how things work. That's how we're built. So my general thought has been to see if you could use abstinence reinforcement intervention as a maintenance intervention. So it would be nice if you could, you know, present something for a brief period of time and see irreversible effects. But that's not possible for a lot of things, methadone being one of them. But there's a lot of other things, you know, using treating diabetes and so on. So I've been investigating for a while now, looking at abstinence reinforcement as a maintenance intervention. So this is just one study in which we took a methadone patients who were using cocaine again, and it looked at them over a 10-week period, and randomly assigned them to 3 groups. One group continued just getting methadone treatment. They got counseling once a week, and they got methadone doses, daily methadone doses, but they continued to provide about 15% negative for cocaine, urine samples negative for cocaine over the whole year. So this one thing is important about this study is that it's over a year. These people got take-home methadone doses, which are attractive to some people. If you have a urine sample negative for opiates and cocaine, you get to take on Monday, you get to take home a methadone dose for Tuesday, which means you don't have to come back to the clinic. And if you have an opiate cocaine for urine sample on Wednesday, you get to take home for Thursday, and similar for Friday. You know, it's attractive because people don't have to come to the clinic every day if they get take-homes. They also could sell it. We tried to, you know, use procedures to reduce that, but that happens. Anyway, it's a good reinforcer, but it's not, you know, really powerful. So this is the percent of urine samples that are negative for cocaine. It increased but decreased by the end of the time. So, but these guys got the same take-home condition. They had urine samples negative for opiates and cocaine to earn vouchers. I mean, to earn take-home methadone doses. But they also got a voucher intervention, which they can earn monetary vouchers for providing cocaine for urines. And that condition, that was maintained for a full year. And they get, it's about the same rate as $1,155. They got $1,500 over a year. If you calculate that out, it's about the same as $1,155 over 12 weeks. And it maintained cocaine abstinence. There's a lot more to say about this study, but that's all I'm saying. Okay, so we've also been interested more recently in promoting adherence to antiretroviral medications in people who are living with HIV. And, you know, just like other problems, being poor is bad when it comes to HIV. This is the percent of HIV diagnoses in different census tracts in which an increasing percentage of people live in poverty. So this is men and this is women, and essentially HIV diagnoses are much more common in people who live in high poverty areas than in low poverty areas. It doesn't matter how you got HIV, whether you got it through heterosexual sex, whether you got it through injection drug use, or whether you got it through sex by men who have sex with men. Both the three major routes of transmission of HIV, and it's true for women too. You know, poverty is also related to this. Antiretroviral medications are like magic. If you take them every day, it decreases the amount of HIV in your body, in your blood. And the amount of HIV is called viral, in your blood is called viral load. And this is a real viral load for a person over a course of a year. You can see that this person was taking medication every day, and her viral load decreased over the first 8 weeks or so, gradually, but consistently, and then stayed essentially at the level that the test could detect. This line, dashed line, is what we call an undetectable viral load threshold, which varies depending upon the study and for a variety of reasons that are not that important for this talk. That we use this threshold, 200 copies per mil. As I mentioned, if you take your antiretroviral medications every day, you improve health, increases lifespan, and really important, you know, you might not care about the people who have HIV. I mean, I personally do, but if you don't care about them, it also reduces transmission of HIV. So the society is protected if people take their antiretroviral medications every day and have undetectable viral loads. So no matter how you slice it, it's pretty good. The antiretroviral medications are pretty good and important. There have been a lot of different ways to try and get people who don't take antiretroviral medications to take them. And kind of common, you know, things that you might, that look better than incentives, but they're really kind of weak. They have very weak effects, and the ones that do have weak, small effects, you know, their effects wane after the intervention ends. So people have used incentives to try and promote antiretroviral medications. Some studies have used MEMS caps, where they, you know, get incentives for opening pill bottles, and these have been somewhat effective, but it's not clear. But they've not really significantly increased undetectable viral loads. Some people have used incentives for viral suppression, and they've been in some small studies, and there's some big multi-site studies that have used it also, and they have used kind of silly contingencies, which, like this study, which was done by the HIV Prevention Trials Network, you could get $70 if you have undetectable viral load at 3 months. You know, that's kind of crazy. So you have to take medication every day for 3 months, have undetectable viral load, and you get $70. So, and it produced, it actually produced a significant effect because they had 16,000 people, but it was like an increase in 3%, increase of 3% in the percentage of people who had undetectable viral loads. This was a multi-site study done by the United Clinical Trials Network that offered $150 over for an undetectable viral load at 3 to 6 months, I think, and it produced no effect. The incentives had no effect. So I actually heard about these before they were published and realized, I think we could do something about this. And so we wrote a grant and it got trashed initially, but they had good suggestions and it got funded the second time. So in this study, we take people living with HIV who have detectable viral loads. That's how you get in the study. You have to have detectable viral loads. They get HIV education and computerized HIV education that we provide. After they get that, they get randomly assigned to 2 groups, a usual care control or incentive group. And both groups are monitored every 3 months for 2 years, and for 6 months, every 6 months for the third year after that. The people in the incentive group they can earn $10 per day. Initially, because it takes, remember that woman I showed you, she took 8 weeks to get undetectable viral load. Initially, they can earn incentives for having decreases of 30% per week in viral load. And we do random and decreasing viral load testing. So they have to call up every Monday, which they get $5 for calling. They ask, do I have to give a blood sample that week? If they have to give a blood sample that week and they come in, they'll schedule it, come in, and give the blood sample. We'll send it out for testing. If they have an undetectable or viral load or decreases by 30% per week since the last time they provided a sample, they get $10 a day since the last time they provided a blood sample. But as long as they continue to provide, meet the criteria for decreased or undetectable viral loads, the frequency of testing increases, and it goes to random. So they'll call up 1 week and they'll say, do you have to give a blood sample? And the answer is no. But if you come in next week, you'll make $280 if you provide a blood sample. And that system, eventually they get to where they're providing blood samples once every 12 weeks on average, always random. And it lasts for 2 years, and they can earn $7,300 over the 2-year period, and we apply the incentives through reloadable credit cards, so they never have to come in to get that money. So this slide just shows them demographics of the people in this study. 102 people. About half were male, 89% were black, most were unemployed, 82% live in poverty. So we didn't actually pay attention to their income or employment status. They had that undetectable viral loads. But by selecting that, this is what we got. Not many people are married. So, it was kind of consistent with what we have seen. And so this study is still ongoing, so I'm only going to show you some data of some of the people. This slide shows that intake viral load for the two groups. The dots are individual people. The bars are group medians. This line is undetectable viral loads. So you see all the people in both groups had detectable viral loads because that's how they had to get into the study, and the distributions were pretty similar across the two groups. And this is at intake 3, 6, 9, 12, and 15 months, the percent of people with undetectable viral load at those time points. So at intake, as I just showed you, no one had undetectable viral load. But at 3, 6, 9, 12, 15 months, significantly more people had undetectable viral load in the incentive compared to the usual care. So these had about 80% undetectable viral load in the incentive group compared to about 40% in the usual care. So also, you should know, all these people are in medical care. And I'll tell you, those clinics don't fool around. They really try hard to get people to take medication. But in that context, the incentives really, if you have the right incentive contingency, right magnitude, right schedule, and so on, you could really affect behavior. Okay, so we've conducted another series of studies to see if we could try and develop what might be a practical application for incentives. I mean, it's not a good situation that you have to use high magnitude incentives and you have to maintain them for long term, because how could that be possibly financed? And the truth of the matter is, even though we've done this research, I can't say that we've solved that problem, but we did try to see if we could use employment as a vehicle for arranging abstinence reinforcement contingencies. So the procedures that in our what we've called the therapeutic workplace are pretty simple. We hire poor, unemployed people to come to work, pay them to work, and we require they provide drug-free urine samples. Now, we used to require that they provide drug-free urine samples to get access to the workplace and to maintain maximum pay. that was kind of painful because people would travel all the way to the clinic and to our program, and they'd have a positive sample. We had to send them home, and that was not good. It also discouraged retention. So we changed, and in the more recent studies, we've just decreased the magnitude of pay and allow people to work, and that seems to work pretty well, and we maintain better retention. So that's the basic scheme. So we treat poor, unemployed people who have few of any skills. We have 2 phases of treatment. In the first phase, their job is to participate in intensive training. They get monetary vouchers exchangeable for goods and services, or we are more frequently using these reloadable credit cards. Once they get abstinent and skilled, they could move on to phase 2, where their job is to perform a real job. They get paychecks, and theoretically, this phase could be indefinite and maintained indefinitely, as long as they're doing something valuable for the workplace. So we've made 3 models of how to handle that second phase. I'm going to just talk about the social business model and the wage supplement model. So the social business model, in phase 2, we hire them to be employees in a business that we operate. And I'll show you about that in a second. And we maintain contingencies in which they get paid for working, but they also have to have be abstinent to maintain their maximum pay. Wage supplement model is a circumstance where we encourage them to get employment in the community. We use this program called Individual Placement and Support, which is a support employment intervention for people with severe mental illness. But if they get a job in the community, they get wage supplements, and for every hours they work, and they have to continue to provide drug-free urine samples, and the magnitude of the wage supplement it gets decreased if they have a positive or missed sample. We made a data entry business called Hopkins Data Services. Actually hired people to become data entry operators in this business, sold the data entry services to people outside of, a lot of people in public health. They do questionnaires, and other people as well. The first study we did, we took patients from the Center for Addiction and Pregnancy, randomly assigned them to usual care control and therapeutic workplace group. These people we kept in the workplace. We monitored for 4 years, which I'm going to show you some outcomes. Therapeutic workplace participants were invited to come to the workplace. But at 3 years we actually didn't have a business at the time, which is why we waited till 3 years. But we opened the business, and these people went into the data entry business. So this slide shows the 20 people who were in the therapeutic workplace group, and each line is a different person, and the thin portion is when they're in phase 1, and the thick is when they're phase 2, and that's whenever they're attending. So they have to be abstinent to attend. In this study, this also shows abstinence. So, about 40% of the people maintained pretty regular attendance over 4 years and got into the data entry business. And this slide shows data that we collected for both groups, the percent of urine samples negative for cocaine at months 1 through 6, months 18 through 36, and months 37 through 48 when they're employed in the data entry business. And it's pretty clear they maintain significantly higher rates of therapeutic workplace participants maintain significantly higher rates of cocaine negative urine samples than usual care controls, and that maintained even when they're earning, essentially in the business, they're earning regular paychecks through like ADP payroll we used. Oh, I couldn't remember what this was. Oops. Okay, so this study showed pretty clearly that we could use the therapeutic workplace to maintain abstinence. It didn't show that we needed to maintain the therapeutic workplace to maintain abstinence. It could be that we could have, exposed them to the workplace for a short period of time and maintain abstinence. So in this study, we took patients who were in methadone treatment around Baltimore City, invited them to come to the workplace. They went to 6 months of phase 1, and after that, the ones who got abstinent, and we initiated abstinence contingencies, we've learned that you let people come to work for the first month or so, independent of your analysis. So they get exposed to the workplace, learn that about our voucher system or reloadable credit card system, and learn that we don't have two eds, a decent place to be. And after a month, we had abstinence contingencies for opiates and cocaine, and typically sequentially. And then we randomly assigned them to two groups. So the ones who got skilled and abstinent randomly assigned to two groups: an employment-only or abstinence contingent employment group. Employment-only participants could work independent of your analysis, like a regular job. So this is essentially what would happen to these people. They got abstinent in our phase 1 in 6 months, but what happens to them if you give them a regular job in the community? This is a model of that. These guys had abstinence contingencies maintained for the full year. So that is, they had to continue to provide urine samples negative for opiates and cocaine to maintain their maximum pay. So these are, each row again is a different person. Each box is a Monday, Wednesday, Friday urine sample, and the yellow are cocaine positive and the blue are cocaine negative. So you can see, initially when people can come to work independent of your analysis, people continue to use cocaine. But after the contingency, which is about here, it actually varies in a way that's not that important. People started to provide cocaine negative urine samples, and generally there's a lot of blue, which means a lot of cocaine abstinence. Then we randomly assign them. Now these people no longer have to provide urine samples negative for cocaine, and it's not a pretty picture. They relapse. Many of them relapse to cocaine relatively quickly. Some people don't, but there's a lot more cocaine. These people have to maintain cocaine abstinence to maintain maximum pay and access to the workplace, and they do maintain pretty high rates of cocaine abstinence. So this just shows some similar stuff, but it also shows some data that's not too pretty, but true. After the intervention ends. So at intake, this is the percent of urine samples that are negative for cocaine. At the end of 6 months training, this is the percent of participants that are cocaine negative, that had to get cocaine negative to be in the study. Then they get randomly assigned to the employment only and the employment only and the abstinence contingent employment groups. And about 50% of the urine samples are negative for cocaine in the employment only group, but 80% are negative for cocaine in the abstinence contingent employment group. And this is for the full year, 6 and 12 months in the data entry business. And this is the unfortunate reality. At the end of that, we still followed them up for another year, and they're pretty much the same. So yeah, I don't know what could maintain abstinence in this, but this probably could, abstinence contingencies. But no, other people have tried cognitive behavioral relapse prevention, things like that. It's not that good. But this maintaining abstinence contingencies is probably the best way. We've also done a series of studies in which we used the therapeutic workplace to promote medication adherence. So naltrexone is the best example, and we've done a few studies with that. Naltrexone is an opiate antagonist, terrific medication. If someone's taken naltrexone regularly and used heroin, they won't feel the heroin, and it could be a terrific medication except for one minor detail, and that is no one will take it. So we use the workplace to see if we could maintain access to adherence to naltrexone. The contingencies are pretty similar. People at work and earn wages, but they have to take scheduled doses of naltrexone to maintain access to the workplace. We did 3 studies, one with oral naltrexone, one with an extended release naltrexone formulation called Depotrex that'll never see the light of day, and one with Vivitrol extended release formulation. This actually was approved by the FDA. In all 3 studies, they go through an opioid detox, because if you give naltrexone to someone who's currently physically dependent on precipitate withdrawal, so they go through opioid detox, they get into oral naltrexone, in which they have to take naltrexone doses, essentially Monday, Wednesday, Friday, to get into the workplace, and then they get randomly assigned for 26 weeks to a prescription or a naltrexone contingency group. prescription people are offered naltrexone, but they don't have to take it, and contingency people have to take scheduled dose of naltrexone to work. So I'm just going to show you some data for the Vivitrol study. This is the percent of people who are retained in the workplace, and both groups are retained in the workplace pretty comparable rates and fairly high rates over the 24-week period. But this is the percentage of people that continue taking Vivitrol injections, and 74% of the people in the contingency group took all scheduled injections, but 26% of the people in the prescription group did, which was a pretty big difference. So Vivitrol may be good, but a lot of people, even that doesn't solve the problem of adherence. A lot of people stop taking it when they have a choice to take it or not to take it. So in all those three studies, what's kind of interesting is that we saw on all three studies kind of comparable effects, increasing naltrexone adherence, but we did not see effects on opiate use, which is a little bit weird. You know, naltrexone should be decreasing opiate use. I can't actually show you this. I'll show you a little figure later. The real looks like one of the main drivers is people who use cocaine also use opiates, even under naltrexone blockade. So cocaine is bad. Remember that. So Brantley Jarvis did just combined the three studies and saw a small significant effect. So naltrexone, I mean, it's a great medication, really, and it did have an effect, but it only had a small effect on opiate negative urinalysis, and we were only able to detect that when we had a big enough sample. So we conducted another study. Mr. Coffin has helped design this one. Dr. Confidence, I should say. So there's similar design. Everyone had an opioid detox. They had oral naltrexone. They took oral naltrexone, and then they're randomly assigned to 4 groups. One group got naltrexone injections every 4 weeks, just like the previous study. One group got opiate abstinence incentives, in which they had their pay decreased if they had opiate-positive urine sample or missed a scheduled sample. One group got both naltrexone and opiate abstinence incentive, and one group got neither. So this is the urinalysis results for those 4 groups. Each row is a different person, you can see. And you can take a look at the group that got naltrexone injections. This is opiate-positive urine sample, opiate-negative, blue again. And you can see that these people, a lot of these people were taking naltrexone injections but still using opiates. But when we combine naltrexone and opiate abstinence incentives, we have significant decreases in opiate use, no matter how you handle missing data. And in these, we only have 2 people who had positive urine samples for opiates, and not while they were taking naltrexone. So we've conducted a number of studies. Actually, there's a little bit more than are shown here, but just generally speaking, voucher reinforcement increases abstinence or adherence to medication, and employment-based reinforcement in the therapeutic workplace does the same thing. Okay, so this is the last topic. That's a lot of stuff. But we're really interested in reducing poverty. Reducing drug use is a lot easier than reducing poverty. We really are just turning our attention to this in a more serious way. But it's pretty hard. We've done a number of studies over the years just showing that we could use, that we can invite our people, poor unemployed people, to come to the workplace, that they'll come if you pay them. They won't come if you don't pay them. They'll come if you pay them, but if you don't pay them to be productive, they won't be productive. They'll come, but they won't be productive. If you pay them to come and be productive, they'll come and they'll be productive. Generally speaking, that's the case. And those kind of, I think they're good studies, but they don't really, get people out of poverty. They just show that these reinforcement contingencies are important if you want to get people to come and be productive, either in training or in work. So we have looked at the effect of these different models, social business model and wage supplement model, on getting people employed and hopefully increasing income and reducing poverty. I just talked to you about the data entry business that we had, and the design. This is the same design of the study that I showed you before, the first study that we did with pregnant women. But this shows you the percent of months that they reported being employed full time in the year when the business was opened, and it shows the percent of people employed is significantly higher in therapeutic workplace people compared to controls. These are all the people who are coming to our data entry business. So one thing is important to remember: these were pregnant, postpartum women from the Center for Addiction Pregnancy. Either had, all of them had kids, very young, kids, when they were, soon after they were in this study or when they started the study. But most of them were unemployed. Well, all of them at the start of the study were unemployed. But 4 years later, they're still unemployed, and they're in the welfare system. They have whatever pressures are, required to do that, but they still are unemployed. But if you offer them a job, they come. They pay them, and even if they have to stay abstinent. Well, not everybody, but a good number of people. Unfortunately, we also looked at their employment in the years 5 through 8 after they left, after we closed the business, and some people stayed employed, but enough people stopped employment to make this no longer significant. Now, maybe if we had a bigger sample, we'd see an effect even afterwards, but we didn't. Okay, so this is the last study I'm going to show. This study is still ongoing, so I'm only going to show you some preliminary data. But this is a study that we're currently conducting. We took people who were in methadone programs or buprenorphine programs around Baltimore City, invited them to come to work, and over 3 months required that they provide urine samples negative for opiates, and then opiates and cocaine. And then we randomly assigned them to 2 groups. Both groups got an employment specialist for a year. And the employment specialist tried to implement something close to individual placement and support, which is that employment intervention that I mentioned that people use with people with severe mental illness. They've actually done a bunch of randomized controlled trials used all over the United States and actually around the world. So that's the intervention to get people employed. But these guys got the same employment intervention, but in addition, they got abstinence contingent wage supplements. So abstinence contingent incentives. Initially, before they get a job, they get incentives for working with the employment specialist. And if they get a job, they get wage supplements for every hour that they work. But the magnitude of those incentives is highest if they stay abstinent. If they have a positive urine, it decreases the magnitude of the incentive, and gradually increases, similar to what we've done in other studies. So as I say, this is only preliminary data, but this is 32 people in the IPS and incentive group and 31 people in the IPS only group. At intake, about a little over 20%. Both groups are negative for opiates and cocaine. At the end of 3 months, 80% are negative. They don't have to actually be negative to progress. They just have to actually be still coming in this study. And then they get randomly assigned to the 2 groups, and over the first 4 months, it's pretty clear that the percent of urine samples negative for opiates and cocaine in people in the IPS and incentive group is way higher than people in the IPS only group. So this is attendance in the workplace, attendance and employment. This is attendance in IPS. So one thing is, if you look at the group who just get IPS, no incentives, they pretty much just stop coming. So, I mean, it's not like these guys have great things to do. They're poor, unemployed, and they have demonstrated a willingness and interest in coming, but they stop coming to the workplace, stop coming and don't work with the employment specialist. But the people with the getting the incentives for working with the abstinence contingent incentives for working with the employment specialist, they continue working with the employment specialist. Now, this is 4 months of employment, which is not too pretty. IPS data also don't look at 4 months. It takes people several weeks several months to get employed. So, and we're actually doing okay. It's not easy, but I mean, people have criminal histories, and we have like a lawyer from the Legal Aid Society that comes every Wednesday to do an expungement process with people to try and expunge criminal convictions, and it's hard. But we might actually succeed. This doesn't say it doesn't show that we do. But one thing is clear: if you combine IPS and employment, the abstinence contingent, people get abstinence contingent incentives. They keep on coming work with the employment specialists, and we'll see if they get employed. I'm not sure yet. IPS only people, as I mentioned, don't come. Some of them do get employed. So the conclusions are pretty simple. Incentives at the therapeutic workplace can both promote and maintain drug abstinence and medication in people who live in poverty. The workplace may be useful in reducing poverty in low-income adults who have histories of drug addiction, but we need to continue working on this to show if that's the case. And incentives in the therapeutic workplace may be useful in addressing other poverty-related health disparities, which is projection, but I think it's probably true. That's it.
We have time for some questions. I'll start. So Ken, like I know right in this neck of the woods, there's been news articles about they can't find enough people to hire who can pass drug screening tests, right?
Yeah.
And that's a big concern of employers, and
That's interesting.
And it seems like you got a solution for them.
Yeah. Our people have to get drug screened too, and it's a problem. It's if someone, not everybody has gotten abstinent and stayed abstinent, and it is a problem. But yeah, you're right. I think I mean, the truth of the matter is, there's a company called American Substance Abuse Professionals that actually works with regular workplaces like UPS, FedEx, and they actually if someone has a drug problem who is employed, they'll refer them to substance abuse treatment. They can return from substance abuse treatment, but they have to take a return to duty drug test. If it's negative, they get to work. And then they go on a random drug testing schedule that could last for 5 years. And the contingencies are a little brutal, but I think they could actually lose their job if they have another positive. But that probably varies. But I think these principles could apply to address the problem. Not easily, but it could. Yep. Yep.
So speaking of these principles applying, like right now, I know there's a lot of conversation about adding employment contingencies to SNAP programs.
Yeah.
And there's always, various contingencies for abstinence or employment all throughout the welfare system.
Yeah.
But the major criticism I've heard of that is that it costs money to add those contingencies, and isn't it better to just spend that money in welfare programs? So have you looked at how much it costs to add these contingencies to, like, your workplaces? Or, how does it scale? Is it even possible?
Yeah.
To do
I don't. Well, if I was a better scientist, I'd have the right answer for you, but I don't actually know. We did do cost analysis, and the cost of the program is not much. It's pretty reasonable and modest compared to, like, it's a little bit more expensive than methadone programs, a lot less expensive than inpatient treatment programs.
Right.
We're currently, stepping up a little bit and got health economists to be involved in our current trials, and they're trying to address that issue in a way that, I don't really know how to do that. But yeah, so we might know. I mean, it's not free. It's going to cost money, and people have to be willing to pay for whatever benefit might be obtained. But yeah, it's not. I don't really know the answer. Yep.
You talked about how reducing pay based on contingency is a clean urine test.
Yeah.
Clearly, there's a discounting mechanism going on there. Do you have any insight into how badly that pay is cut, how that will affect the results of
Yeah.
abstinence?
Yeah. Well, not really. We don't really know. I mean, it's difficult to do these studies and to get parametric, do like parametric analyses. Like people will probably not fund that. I'm not afraid to submit anything that type. So I don't really know. We make it pretty extreme. Extreme is good. And probably, my guess is, if you do less extreme, it'll be less good. Yeah, but yeah, I'm just making that up. All right. Well, thank you very much. Huh?